with this introduction, I have my great pleasure to start the conference. And we have 4 talks from eminent people. And I will start with treatment resistant. Then John Crystal, our past president, will continue with fast, rapid and antidepressants. And thereafter, we will have Professor Fontolakis from Greece talking about his specific area in schizophrenia. And finally, we have then Professor Jiku talking about also schizophrenia. So I will start my first presentation, which is on treatment-resistant depression. And I hope everybody can see. Can you also see what I'm presenting here? So, conflict of interest, very important. I think we have to have a partnership together with the industry, with clear regulations, which we have also with CINP. But without the industry, we wouldn't have all these wonderful medication which we have now. And I have to say, no university in the whole world ever brought any medication forward. Although we have ideas, but then the industry has the resources then to produce it, like we hear later then also from John Crystal. So now is a kind of an echo in the room. Is this, probably I should not use this microphone or should put it over here. Okay, so where are we today? And I hope you agree that we have very good treatments available for our patients. Most patients who respond to the treatment don't see us as psychiatrists, don't see us in the university settings. They are treated with the GPs already.
You use this.
Oh, sorry, I use this one. And, but in university settings, then we are confronted with the 3rd and 2nd line treatment. Usually they are associated with worse outcome, and we know that there are specific treatments available for these patients. So what we learned also from different studies, STAR-D study or the European study, switching is not the best, so augmentation is very likely to be the better. We also know that without remission, there is a recurrence is very common. Professor Pekale, in one of his early papers in 1996, he pointed this out already, and in these days there was no story about remission and recognition, but we know it from these days. Partial remission is quite important, and because if we do not have partial remission, then we have a worse outcome. We would love to have biomarkers, but unfortunately right now we do not have strong biomarkers, although we are getting towards these biomarkers, and although the academia has a great understanding of the underlying biology. Like today we had and yesterday a program meeting of the CINP, and we had wonderful new thoughts, but unfortunately these biomarkers and the understanding did not reach the everyday clinical practice as yet. We need also effective treatment for quick onset of action and sustained efficacy, and we hear later that there is new hope on the horizon for quick onset and hopefully also for sustained efficacy. So we recently put a paper together in Translational Psychiatry about biomarkers which we know from the literature. So we know like the hippocampal structure of MRI could be used, the translocator protein could be used, then the network connectivity could be used. Recently in the CINP journal, we put a series together about making sense of connectivity. So unfortunately, we do not use this language then also in our everyday clinical practice, but we could do so if we teach the neuroradiologist and all these other professions to look at these specific paradigms, which they have to learn from us, because usually if you send a patient to MRI, then we come back, no stroke, no tumor, forget it, right? But we're not looking for stroke and tumor. It's lucky that they don't have a stroke and tumor, but we would like to look at network connectivity. The receptor transporter, you know, our colleagues in neurology, when they look at the dopamine transporter, they say, well, 20, 30, 40% reduction. We have the same data available about these, but we don't look at these different structures, what we could look because they are available. So it's not so easy. In this paper we also described that there are some candidate markers. We have different terms for it, different applications. That would be a whole talk to talk about these different applications and terms. I would not want to go in detail, but the predictor, predisposition marker, screening marker, staging marker, quite important, would be topics to cover in future publications. You probably do not know this gentleman anymore. This is Ronald Koon, a Swiss psychiatrist. In these days, they published in the Schweizer Medizinische Wochenschrift. Nowadays, everybody publishes in biological psychiatry. I don't know why, but they don't accept any Swiss German papers. But he was the first to study imipramine, right? When you gave him 20 minutes, he didn't stop after 2 hours, right? So he was a very dangerous speaker. Only his wife could say, "Now you sit down," right? So that's what he did. And you see the story went on. And I don't go into detail, but the new kid on the block is ketamine down there, which you hear later on. And this is a big development. And I was a young student when the SSRIs came. I'm quite sure that ketamine opens the field to a completely new area. So we know the animal literature, and we know that there are different derivatives coming afterwards. So it's the first lead compound for studying the glutamatergic mechanism of action. Those of you who want to go in more detail, so in the World Journal of Biological Psychiatry, we have all the different treatment guidelines. You see 2013, no ketamine in there. Seeing how fast the field moves, right? So it's quite interesting. If you look at these papers, you have the older literature there, but not the newer literature. Let me show you a European program of treatment-resistant depression, where also our Vice President, Joseph Sohar from Tel Aviv, is participating. And you can also see that Vienna is right in the heart of Europe. Yes. Direct flight with EVA Air, 12 hours, unfortunately very long. But you have different centers, Brussels, Paris, Geneva, Halle, Germany, Italy, Athens. We work together since 15, 20 years nearly. I remember when I got an invitation for this treatment-resistant group, I say, what the hell you want to study? Treatment-resistant, we solved depression. No, it's treatment-resistant, but later on it developed. Well, this is a very important topic. So now, very busy. We studied over 2,700 patients, and we looked at clinical parameters, biological parameters, and also some treatment parameters. And I will show you a few parameters out of the study group. So keep in mind, this is a very nice program, not as like the STAR-D study everybody knows. The GSRD study nobody knows. So I hope with there is not good marketing. So Joseph, we are doing something wrong. I'm quite sure what, but hopefully we have to do it. So it's a very nice program. So what is the specific on these characteristic days? No exclusion. We include every patient who responded, who did not respond, or was a remitter. And regardless if he has additional diabetes, hypertension, cancer, whatever, they're just included in the database, and we record this. And based on this database, then we make recommendations. We also include patients with suicidality, even if they had a severe suicide attempt, so we can address these different questions based on the clinical as well as biochemical data. So a few years ago, we summarized the findings in these days, and what you experienced clinicians know probably. If a patient has comorbid anxiety disorder or has a suicide risk, you see the odds ratio go up to 4, that the patient is very likely to have a treatment-resistant pattern. So this is, of course, experienced psychiatrists know this, but it's not acknowledged in the clinical praxis enough to have this high odds ratio in this group of patients. So there are different ways, like the TRD1, which was earlier studied, then the TRD3 was later studied, nicely sized, 700 or 900 patients. We were interested which clinical parameters sort of are going together with treatment resistant. There were some parameters over here, some parameters over here. And with machine learning techniques, which they take all the different parameters together, so we could confirm that anxiety disorder, suicidal risk, the number of major depressive episodes are triggering the treatment resistant. It's just published in European Acta Psychiatrica Scandinavica. Just one jump over to the other side of the continent. The STARS-D study also showed us that if a patient has in this case, co-syndromatology, so depression with anxiety, they have a worse outcome in the treatment in these days with citalopram than the ones who don't have it. So, and I don't show you the data, but if you give atypical antipsychotics or if you give lithium, then the outcome is better. Lithium was not better in this STAR-D study, but usually it's better. So one very interesting finding is also the number of major depressive episodes on this large cohort. When there were more than 3 episodes, the likelihood was very high that they got treatment-resistant depression. I'm always astonished when I do rounds in my hospital and I ask the younger doctors, how many phases this patient had already? They said, oh, how many phases? No, he's married and he has this and this job. But usually they don't count the phases. But the phases, I think, are very, very important because also large WHO study, for instance, from Jules Angst from Zurich, indicated after the 3rd phase, it's very likely that you have a very chronic course of illness, as pointed out in this data set. That's a French study which I would like to show you and just remind you that remission is associated, that treatment started earlier and with a low number of initial symptoms and for the first episode treated. So all these treatment paradigms which have a wait and see attitude are not very good because the patient needs to be treated effectively at the start, like in other diseases, internal medicine, hypertension or diabetes. What kind of treatments do they get in Europe? So that's a pharmacoepidemiological study based on our GSRD study, which were published in the European Neuropsychopharmacology. So those are depressed patients. Which kind of medication do they get additionally to the antidepressants? So they get benzodiazepines, although there are some parts in the world where they say, well, you shouldn't get benzodiazepines. You see 1/3 get benzodiazepines. Although they didn't read the Pierre Blier's seminal work, they used other antidepressants, most likely mirtazapine and trazodone. So Pierre, interestingly, they didn't read your articles, but they do it. And thank you very much for doing this very good study to prove this is a good approach. And antipsychotics. So the numbers are low here for antipsychotics, just 24. If we in inpatient treatment also, the figures would go up to 50% in Europe. So mostly Seroquel, olanzapine and risperidone, and mood stabilizers also a small fraction. So this indicates that the antidepressants are not enough. We need to do something extra to these patients. Quite disappointing slide. So the bosses in this room, please, there are a lot of bosses in this room, right? But bad outcome if you are getting depressed. Not good, right? So we first thought, well, if you have a higher occupational level, you have a better outcome because you can use all the resources. But unfortunately, and what we discussed also in this paper, they have to have a good cognition, and cognition is impaired in depressed patients. That's one point. The other point is they have 2 different possibilities to choose. Like in Germany, Austria, very often they choose herbal medicine, for instance, which work to some extent, but not to the extent in the other ones. So Professor Zohar here was, I think, spearheading this program. Thank you very much. That it was the first paper, then it was confirmed in another paper, and there's also opinion paper, psychological medicine available. So it's a very important topic, I think. What I think we should also think about different stages of treatment. So like starts with monotherapy. Ideally, the second would be augmentation, or in very rare cases, switches if there are side effects. And the 3rd stage and 4th stage are then the different further stages. I personally think also that we should push away from the term treatment-resistant depression. When you look at other parts of medicine, Is there a treatment-resistant hypertension? Is there a treatment-resistant diabetes? Is there a treatment-resistant asthma? I think sometimes we have strange wordings like atypical antipsychotics. So I feel more comfortable talking about stage 3 depression. So that would be more neutral. Of course, we can have to check out all these different things which we put there. So for pharmacogenomics, probably the cytochrome P450 is important. In Vienna, in our hospital, like 10% of these patients entering our hospital, it's a tertiary referral center, they have changes in the P450 system, quite often hypermetabolizers and with low blood pressure. So a low blood level of the medication, I'm sorry. So let's focus on the third line treatment. So we do quite well with the first line treatment, probably second line with add-on. So the third line treatment is usually 1/3 of the population in depression needs this third line treatment. You hear much more about this, but I think we cannot say it often enough that the FDA, the American Food and Drug Administration, on the 5th of March approved the nasal spray medication, and this goes back to the excellent work done in Yale, spearheaded by John Crystal. And thank you once more for doing all this work, which finally led to approval. The European agency, the EMA, takes usually twice as long as the FDA. So in Europe, we can await approval probably, hopefully, by the end of this year. You never know. So hopefully this will be done then. 2 years ago, we wrote a nice paper about the administration from ketamine, which does not have the newest literature in there, but it has the literature until 2017 in here, if you want to look at the medication in these days. At the end, I'm coming to the end, I just would like to show you some cases, because we are a lot of patients in our hospital get ketamine infusion, so we were worrying, well, what if you give the irreversible tranylcypromine together with esketamine? Of course, based on our brain imaging studies, we know it doesn't do anything to the serotonin transporter. We knew it doesn't do anything to the norepinephrine transporter. So I wouldn't like to encourage you to do it in private practice, but if in the hospital you have the setting, these are cases which you can do also combine. Another question is, do schizophrenic symptoms go worse because you have this dissociation at the beginning? Our work and also other works, I think from Taiwan, there is also a series of publications that you safely can do this. And when you ask the patient about the dissociation, they say, no, psychosis is different to what I experienced here. So it's another dissociation, and we know, and we will hear, that dissociation is not linked to the antidepressant response. So this is fair to know. At the end, what about electroconvulsive therapy and ketamine narcosis? So anesthesia, altogether the data indicate you don't have any advantage if you do ECT under ketamine anesthesia. In this case, the patient was first having normal with metformin anesthesia and did not respond even to bilateral treatment. And then we gave him ketamine, and this patient suddenly went up. So if you have these treatment refractory patients, think about also about ketamine anesthesia in very rare cases. So with this, I just show you once more our work in the CINP journal that ketamine does not influence the serotonin system in the dosage which we use in clinical practice. It starts influencing it when you go up to anesthesia doses like 700, 800 milligrams. And I would like to point out in monkey research there is some influence, but in the dosage which we use, it doesn't influence the serotonin transporter. And I'm coming to the end of my presentation, which you hopefully gave you some new information. We still need new medication. There is room for improvement, also in psychiatry for our medication, and some imaging studies or candidate studies hopefully will help us better to understand it. So early identification and treatment facility are very important. So the wait and see attitude is not good and not done in other parts of medicine. But strangely enough, in Europe, the further you go north, the more you have a wait and see attitude. Specifically, they're also in the treatment guidelines. Like I'm sorry to say, my good friends in Germany, they say, well, first you give psychotherapy for mild. Then you give psychotherapy plus medication. And for the severe cases, you only give medication. So don't talk to patients anymore. So this doesn't make any sense. You have to start early to treat, like you do with high blood pressure, for instance. Then we need, I'm sorry. You need, oh, that's over, game over. So you need new antidepressant with a rapid mechanism of action. And finally, I think it's quite important to see that we have this medication already in place. And with this, I'm finished, and I hope I stayed in time. Yes, that's what I did. So please ask some questions.